Some technical issue here.
We are now broadcasting.
Yes.
Yeah.
So hello everyone. I'm delighted to welcome you all to this webinar about patient-reported outcomes and how they are used in Norway and the US. My name is Christer Mjåseth. I am going to chair this event together with Anja Foghen, a physician at Lovisenberg Hospital, and also Tyler Tang, that will be helping me with the technical part of this webinar. I'm also extremely happy to say that I have in my panel several very talented and distinguished guests, and I would like to start this webinar by introducing them all to you. You will see from New England Baptist Hospital, Dr. Scott Tromenhauser, he is Chief Medical Officer, Chief of Spine Section, Director of Research Administration, and he's also Assistant Clinical Professor of Orthopedic Surgery for Tufts University School of Medicine. Welcome, Scott. And from Rochester, we have three people. We have Dr. Judy Baumhauer, which is a well-known name for those of us who are interested in PROMs. She serves as Associate Chair of Academic Affairs and Professor of the Division of Foot and Ankle Surgery, Department of Orthopedics at the University of Rochester. She is also the Medical Director of the Patient-Reported Outcomes Group for the UR Healthcare System. She is accompanied with Konstantinos Vasalos, which is Director of Rehabilitation Services, Chief of Sport and Spine Rehabilitation at the University of Rochester Medical Center. Welcome, Dino. And Captain Fear, also Senior Data Analyst at the University of Rochester Medical Center. They will show us a very exciting solution related to PROMs a little bit later on. And finally, from my hometown, Oslo, I'm delighted to have with us, maybe Lars, if you can, Dr. Vasli, can you show yourself? Dr. Lars Rosli has been a beacon when it comes to quality work for decades in Oslo. He is the hospital chief of surgery, Lovisenberg Diaconale Hospital, and he has been spearheading this work together with his colleague, Dr. Einar Amli. There you are. Which is also now the CEO of Novo Quality Systems. We have with him Per-Arne Holman, which is Director of Quality and Data Analytics at Lovisenberg Hospital, and it's thanks to him that we have been managed to actually gather you all here today. So, I'll share my agenda, hold on. As you see from this agenda, I will be finishing up my introduction very soon. We will go on to have lectures on 20 minutes from each of the different hospitals. I will let them introduce the topics themselves. During these talks, we will be able to, if you look on your dashboard, you will be able to, as an attendee, ask questions. You can write in questions in the Q&A. We will monitor these questions and we will bring them up during the discussion after each lecture and also during the debate at the very end of this webinar. If we have any time left, we will use also the raise hand function, but so far we will not put that, take that in consideration so far. This webinar will be recorded and we will put out an edited version at a later point, and we will all notify all of the participants about when this is and where you can find it. Okay, I think I've said enough. Like I said, I'm really excited about this webinar and be able to gather people from 3 completely different hospitals. I'm really looking forward to the talk. So I'll give the word now to Dr. Einar Amli from Oslo. Thank you.
Quality register. When it comes to PROMs, we have used it retrospectively to measure benefit of treatment, and it has not been used for indication purposes. Next. I now support Lovisenberg Hospital as CEO of Nova Node, a company that commercializes the quality systems developed in this hospital. Next. My orthopedic colleagues questioned back in 2002, what is the complication rate? What is the results of our surgery compared with the best published results? Can we improve our treatment? We thought that the quality of treatment was good, but we had no answers. We then decided to build a registration system driven by the hospital patient administrative system through well-functioning integration and with analyzing tools that could combine these results from both systems. Next. The system has built and has been improved through the last 15 years. Input is preoperative PROMs using iPads, structured detailed coding of operations with integrated scanning of implants, postoperative PROMs, and we record complications at 3 months follow-up. Data is transferred to our quality database and can be transferred for research purposes depending on informed consent. And we use ClickView as an analyzing tool. Published results are often organized as time-limited projects. To be able to update the register continuously, the different elements must be integrated with the patient electronic record. The PEG system initiates the iPad list and the system automatically brings forward the relevant forms to be filled in. I will in this presentation focus on prosthesis surgery. Next. We started systematic registration of complications 3 months postoperatively. This has been the main core in our quality register. As you can see, fractures must be in focus now with 1.4%, and we are about to reduce this complication. You can see the different complications registered at 3 months follow-up from primary hip arthroplastics. Next. But let us go back to the start. Fractures were not an issue when we used cemented prosthesis stems. It became a problem when we changed to uncemented stems. Dislocations, however, were a frequent complication in the first period, with 2.3% of dislocations in the period 2002 to 2004. Next. Based on hard facts, that is reoperations, we could prove that increasing the head size of the prosthesis reduced the dislocation rate. The left picture shows the volume of 32 millimeter femoral heads in gray. The picture to the right shows that dislocations were reduced dramatically when we increased the size of the femoral head, or in other words, the prosthesis survived 5 times longer. This was an effect we could start this project because the findings in the quality register. But the outcome of operations cannot be measured on rate of reoperations alone. We need to ask the patients. Next. In 2012, we initiated the first major study using PROM in collaboration with the National Arthroplasty Register. Next. The aim of the study was to evaluate patients' experience with 3 different approaches after the 1 to 3 years after the operation. And the inclusion criteria was patients operated between 2008 and 2010, 50 to 80 years with a cementless femoral component and cementless or cemented acetabular component, and with the 2 head sizes, 28 and 32. Each hospital included had to have operated at least 25 hips with the same approach. Next. The patients were asked to answer the following questions. Had complications occurred? They filled in patient satisfaction at VAS score, the same with pain. And we use a 40-item questionnaire called WHOS, which is also including the same elements as in WOMAC score. And we used EQ5D as questionnaires for these 1,476 patients. Next. The WHOS of WOMAC score showed significant lower score for the lateral approach to the hip. Next. The difference was consistent for all subscores. Pain, other symptoms, activity of daily living, sport and quality of life. All showed the same tendency, lower score for the lateral approach. Next. A simple VAS score for pain to the right showed just the same tendency as a 40-item questionnaire. Next. We were surprised to see that complex and simple questionnaires all showed the same difference. This is a VAS satisfaction and the EQ VAS and the EQ5 index. But what was the reason for this problem? Next. A single question to the patient, did the operation cause limping, showed a significant difference for limpers in all subgroups. In Norway, we have a saying that the simple method is often the best. Asking the patients give us important knowledge. Next slide. The conclusion was clear. The lateral approach has significantly lower score for whose EQ5, EQ VAS and VAS for pain and satisfaction. This is explained by increased limping in this group. When corrected for patient-reported limping, there was no difference between the groups. Next slide. This study had a marked influence on the approach used in Norwegian hospital. Lateral approach was the most dominant approach used, but it has been reduced gradually since these results were published in 2012 and is now a minor part of the approach, and the lateral approach is the most common. Next slides. Encouraged by this, we introduced specific and general PROMs in all high volume groups in our surgical clinic. I will give you some examples. This is a slide showing the difference between the preoperative Oxford scores in primary knee arthroplasties. An average preoperative Oxford score was 23 units or 47% function in the knee, and it increased to 39 units or 81% after 1 year. The delta value was 13 units or improvement on over 34%. The average preoperative score was 23. Next. But as you can see from this slide, the preoperative score differed very much. Although the main volume is around 20 to 25, we had some preoperative scores which were very high. It is important to mention that preoperative scores until now has not been used for indication purposes. For those with high scores, we have retrospectively reviewed the patient files and concluded that for only 4 patients, the need for operation could be questioned. Other with high score was found to need an operation. We therefore think that indication should not be based on a fixed score, but this preoperative score may give helpful additional information. We have used the PROMs to measure the effect of operations. Next slide. This shows the effect of different scores for shoulder arthroplastics. The 2 scores to the left, they are specific shoulder score, constant Murley, and VO score, Western Ontario osteoarthritis score, and they show a marked increase in function between 1 and 2 years. But we also find that the function increases after 2 and 5 years on the left. There is also a marked improvement in the EQ5 VAS, which increases after 1 and 2 years. Next slide. The average scores can be split to analyze data on an individual level. This is the examples from the preoperative Oxford score. So what can we learn from patients with worse patient-reported outcome? There are some over to the left which report worse scores than preoperatively. Here we find the complications and some other patient which we can analyze directly and compare with it with the electronic patient record. What about those with low improvement? This is mainly patient with a high preoperative score, and they will have those with high scores preoperatively will have little gain on this curve. So we can learn from the outcome what is the preoperative status of this patient. But can preoperative PROMs behind this result be used to predict the outcome? I think no. But the PASS system has loads of information that can be used. We do not want to include questions in the PROMs to which we already know the answers. We want to combine all relative information and reuse registered data. Next. Yes, we go to next. The analyzing tool allows us to filter on risk factors. Infection rate is clearly related to the body mass index. Between 38 and 44, the infection rate is 465%, and it increases up to 7 or 8% for those with highest BMI. We can combine PROMs with other risk factors, with sex, age, blood values. It's a lot of information in the electronic patient file, and that is why integrated solutions are so important. Next. Additional PROMs and models will be needed for indication purposes, and I will leave this topic to the next speakers. Thank you.
Thank you very much, Einar. I was thinking, in Norway we have registries, and we have a tradition to register a lot of the patients that we see. And I think one of the strengths of the Norwegian data is the compliance rate, the follow-up rate, which is, I personally work with the National Spine Registry, and we have follow-up rates of 80%, 70, 80%. When I go to the US, that is difficult. Why do you think Norwegian patients answer and all these post-operative inquiries that we send out so easily?
Well, I think Norway is especially good in collecting preoperative and perioperative data with detailed registration from the operations and for revision surgery, so we have good data on survival on prosthesis, but the follow-up on PROMs is not especially good. In our hospital, we have about 55% answer rate on the questionnaire sent after 1 year, and one what is called in pudding, one reminder gives additional 20%. So we are about 75% on follow-up. But the national registry has not reached that level, and they struggle to get the data in. Also,
yeah, I think that's common for everyone, and we can discuss that more later. But one of the things that Lovisenberg has been very in the front, really, when it comes to starting collecting PROMs. And like I said, in Norway for research, we collect a lot of data, but we don't really, my experience that we don't really integrate it into the clinical practice. Like you said, you basically said we need to ask the patient. Why haven't we been more in the front on this, you say?
Well, I think we have had a tradition to think that the doctor knows best what is your health. We have now started to ask the patient what the patient think, but it has been a change during the last 5, 6, 7, 8 years.
There's a question coming up here on the Q&A. Why do you think that preoperative PROMs cannot be used to predict postoperative outcomes? You mentioned that in your lecture.
Yes, that is, I then refer to the Oxford score, and the Oxford score alone is not enough to predict the outcome. We could see that a lot of the preoperative score varied a lot for those who need operation, and it can be helpful in condition with other parameters like risk factors and maybe other PROMs, psychological questions, but I refer to the Oxford alone. If we put a fixed level as an indication for operation, that would exclude many who would need an operation. But it could be in combination with other tools. Yeah,
and we will have the chance to discuss that a little bit later on during the panel debate. So thank you very much, Anna. Very interesting, and we will go on. I'm spending this year at Harvard School of Public Health studying, among other things, patient-reported outcomes. And when I started asking around, everyone was pointing me towards Rochester. And the name Dr. Judy Baumhauer was mentioned very early on, saying that you have talked to Judy. And I'm extremely excited and very happy to say that we have Dr. Judy Baumhauer with us today, and she's going to present her experiences with PROMs at Rochester together with Kathleen and Dino. Judy, please. Thank you.
Great, thank you. So I was thankful to Christopher for inviting us to participate, and also for giving us this title, Patient-Reported Outcomes Are a Gold Mine. And I got used to it. I got used to that title over time, and I think they are a gold mine. And Dr. Holman, I agree with many of the things that you've said, and I think that we parallel each other quite well. We have no conflicts of interest with this presentation. I think for a lot of people, they often wonder what a patient-reported outcome is, what makes it unique. Well, it's a health outcome that's directly reported by the patient who experiences it. It's not interpreted by the doctor, the nurse, the tech, but it's all about the patient. This is my very best example that I found in an article in 2008 that the researchers asked questions about breast cancer, of all things, to both the patient and the provider, to compare the answers, so to speak. The first question, is it important to keep your breast? Well, 7% of the patients thought it was important, and yet 71% of the providers thought it was important for the patient to keep his or her breast. What about live as long as possible? 59% of the patients thought it was important to live as long as possible. Perhaps they recognize quality of life is more important than quantity of life. But nearly 100% of the providers thought that the patient should live as long as possible. You see this disconnect, and this is a problem. What the patient finds important should be what we focus on, what we should measure, and what we should manage, because the patient is king or queen. So if you want to know how your patients are doing, you need to just ask them.
Are you familiar with the health assessment on iPads or not? Okay. This is an assessment that your provider will do. It's going to ask some questions about your overall health, as well as what's for you and today. So just read through the welcome screen, tap on begin, and then it's going to be uploaded right into your chart, okay? You're all set. You're welcome. So let me show you what you told me, okay? So as I click this button in outcomes, here is your outcomes information. It tells me that you're functioning a little bit better, and that your pain is getting better, and that you're able to deal with your injury quite well. Great.
So at the University of Rochester, beginning in 2015, we started collecting patient-reported outcomes at the site of service so that we could use that information to guide our care ongoingly throughout the patient experience, if you will. We started with a custom platform because at that time we really didn't have anything else that was available to be able to utilize PROMIS, a patient-reported outcome measurement information system, a validated way of assessing patient symptoms that utilized computer adaptive technology and item response theory. Our cute little name for our custom platform was the University of Rochester Validated Outcomes and Clinical Experience, so UR Voice. This is just a screenshot of the PROMIS and some of the domains or symptom groupings that they have around physical health, mental health, and social health. What made them unique is that they use these symptom complexes instead of disease-specific instruments. What we began in orthopedics is collecting physical function, pain interference, and depression, because patients wanted to physically function better, they wanted less pain, and we recognized that depression symptoms influenced how patients could deal with their injury or treatment plans to some extent. As we got this humming in orthopedics, and we see 17,000 patient visits a month at University of Rochester in orthopedics, other areas of the institution said, hey, we'd like to use that. So sort of through a grassroots effort, we expanded into other areas of our health system. And right now we're about 60 to 70% inclusive of collection of patient-reported outcomes on a one system. So we can all take advantage of all the data that's provided for us on the same graphic display. So the first partners we had was really cancer, and they said these other three were fine, but they also liked anxiety. And there are really several hundred of these symptom things that you can look at for PROMIS, symptom domains. Then palliative care said fatigue was really important. And urology said with urinary incontinence, the ability to participate in social roles and activities was important. So you could see how you could dial in different domains around areas of symptoms that the patient finds important that they want to measure and manage. Since the beginning in 2015 till now, we have nearly 260,000 unique patients, 2.8 million scores. You can see in the central area that the vast majority are physical function, pain interference, and depression. But there are other non-PROMIS patient-reported outcome scores that are being collected, and that component is increasing in over time, as well as pediatric and parent proxy domains. It takes about 2.3 minutes to collect the 3 core domains in orthopedics. This is just a graphic display of what you might see in the electronic record for a patient visits. What do we do? Well, we look at the data, and just like Dr. Holman, we felt that the initial baseline values are important. We need to recognize whether the patient is impaired or not impaired. So you can see there's severity bands here where the red is severe and the green is within normal limits, or good, as I like to say. On the x-axis is time, and on the y-axis is t-score. So PROMIS is measured in a t-score. 50 is the US population, so you can compare your patient to the US norm, if you will. So for this patient, you can see that their physical function, which is in red, and their pain interference in green, has moderate severe symptoms. And their depression symptoms are mild. They're a little sad about how they're not functioning so well. We can also look at trends. We can see that if at the end of this particular episode, the patient has gone up into the good level. So that's a positive outcome. And we can watch those trends over time as we change different parts of their treatment plan. So I always say up is good, down is bad. And that's how we constructed this, so it's easy to view. Here's this same graph in a little more detail and really walks you through what these different data points had happening and what was going on with this patient. So this patient was diagnosed with ankle arthritis, and decision-making was made with the patient initially, and she wanted non-operative management, but it didn't work for her. So ultimately she had an ankle fusion, and you can see that this is drifting down here because she's in a cast, then non-weight bearing, and then she's in a walking cast, then she's out of the cast. We send her over to Dino and his group, and they have this patient recovering with physical therapy. So that's a nice outcome for this particular patient. Here's another example of perhaps an outcome you wouldn't expect, or something that needs to be managed in a negative way. The patient had a hip replacement, and yet their symptoms are declining over the years. Maybe that represents hip loosening. It doesn't diagnose the problem, but it alerts you in a validated way of what these patients' symptoms are. Over to the left here are some other patient-reported outcomes that we obtain in our system. So the patient would ask some questions like, will I be more physically active if I have a knee replacement because I have bad knee arthritis? And yet, when they answer their physical function score, they get a t-score of 47. Well, we look at the data in aggregate as well to try and look at the probabilities of whether or not a patient would improve. So if a patient's t-score is as high as 47, their probability of achieving a minimal clinically important difference is about 88%. It's the chance of them not perceiving that difference is 88%. So this person falls in the bad box, the sad face. Surgery would not benefit this patient, so you want to have a conversation about other choices. And patients take that information quite well. They don't want you to practice on them. They want you to know whether or not the surgery is going to improve them. And that's the delivery that we give to our patients every day. I just want to tell you a couple other ways that you can look at the data, and you can imagine that you can look at this data in many, many different ways. You can compare surgical and non-surgical procedures and all sorts of treatment that introduce variation in care. Our goal is to decrease variation in care, improve outcomes, and decrease costs. So this is a graphic example of 3 different ways to reconstruct ankle ligaments for ankle instability. So there is variation, so let's pick the best one. Here's different variation amongst surgeons. So these are 6 surgeons that do ACL reconstructions. You can see there's somewhat overlap here, so really their outcomes are all quite good. Well, what about their costs? Are their costs all the same? Can we use cost as an indicator to change our care so that it costs us less with the same outcomes? Now I'm going to turn it over for a detailed overview, I guess. I don't know if it's a detailed overview of Provost program with Dino and Kathleen.
Great, thank you, Judy. And am I able to share my screen here?
Yes.
Okay, because I thought for our part of the presentation, we would actually kind of do a live demo of some of the software solutions and kind of business insight dashboards we're developing. So my background is I'm a physical therapist by training. I've been at the university for a while. I'm also interested in business. I have an MBA background and have developed software programs and businesses with the university that we sell and license externally. So I'm very much a clinician, but I'm also very much in operations and logistics and business consultant for the university. And some of this project was really driven by other projects that we had done using patient-reported outcomes to evaluate workman's compensation risk here at the university, and using these tools to mitigate that type of risk or claim. So as Judy said, the U of R has a tremendous amount of PROs collected, probably some of the largest in the nation, if not the world. So one thing I sought out to do to say is, if we have all this rich data, how can we actually build systems where our C-suite executives, our division chiefs, and our individual providers can actually use the data on a day-to-day basis for their normal operations. And one area we thought to use this data is to try to develop a system that can measure value. So just as Judy was saying, we now have health outcomes, right? We have PROMIS, which gives us a disease and profession agnostic outcome tool, because it focuses on domains of life, domains of health that patients, really use to measure our outcomes that we give them, right? How does it affect their physical function? How does it affect their pain? How does it affect their sleep, their anxiety? So we took all this data and we started to build these insightful dashboards. And I did this work with my partner, Kathleen Fear. Dr. Fear is a brilliant, talented young professional, and has done a lot of our kind of design and layout work and the database integration. But essentially we said, my team is a team of over 200 clinicians across the greater Rochester area. We have multiple locations, multiple practices, multiple providers. So how do we take all this PRO data that we have and build it out for our providers to use, and for me as an administrator managing this practice, to evaluate our outcomes and ultimately to evaluate our value. So to take our outcomes and put it over cost, to see where we're efficient, where we're not efficient, and where can we improve. So the first slide here is really a divisional dashboard that I would look at. So in this group, there's 5 different divisions that report up to me. We have a hand and upper extremity division, an orthotics and prosthetics division, an occupational therapy division, a physical therapy division, and a sports and spine rehabilitation. And within each of those divisions, our clinical teams are organized essentially by clinical specialty areas: foot and ankle, hip, knee, shoulder, spine. And then we modulate all this data over time. And then I have offices, multiple offices for each practice. So what you see here is I'm looking at our sports division across all diagnostic categories that the team will see over whatever time period that I want. And the first step is for me to understand, how are we collecting the data, right? So we know it's a burden for patients to collect this data, but if we're going to use this data meaningfully, we have to collect the data. And what this dashboard allows me to do is look dynamically across my offices and across my individual providers, and look at, of the episodes that they're seeing. And an episode of care is a distinct start and a stop of a period of time where a provider will interact or see a patient or perform a procedure. So this lets me look at an administrative level quickly to see, of the episodes that we're doing, what percentage are we collecting full bookend PROMIS or PRO assessments, because we need a start and we need an end to evaluate outcome. And I can influence this dynamically and look across any division that we want to look at. And I use this tool dynamically as the first step to say, if we're going to use PROs, we have to collect PROs. And I have to be able to drill it down to the individual provider, because we know the provider's influence on this is significant. If the provider doesn't ever discuss PROs with the patient or use them in care, as we've kind of set the standard here at the university, then the patient's less likely or less engaged to fill it out, because it's just another, thing that they have to do as part of our workflow. But we can see the providers that are really good at collecting it, and we can work with those providers that are not and help identify workflows that improve their efficiency to collect it. So step one allows us to just have this high level administrative dashboard to see if we can collect. The next step that we dove into was to say, okay, in an aggregate level by division, you know, how do we actually do? What is our outcome? So if you had asked me this 2 years ago, how does University of Rochester's sports division do at treating shoulder conditions? I couldn't answer that question in an aggregate level because I didn't have that aggregate outcome data. And we had individual outcome data, but it differed across diagnoses or professions. With PROMIS, that's disease and profession agnostic, we can now make these broad, you know, data collection assessment outcomes, which, you know, has some meaning. There's obviously you need to get more granular, but I can look at this data. So what this shows is across my sports division, within our knee diagnostic, you know, divisions that are set up that see those cases, what were our starting distributions in the PROMIS domains that we collect? And in our group, we collect physical function, pain interference, self-efficacy, and depression. So, you know, we can see, are they normally distributed? Are they skewed left, more severe, less severe patients? What type of patients are we seeing in aggregate across the 200 clinicians that I have in my group? And then how are their outcomes after we actually do an intervention? So what you see on the right side here is the bookend data. So the pre-assessment here, and then the final outcome assessment in the delta. So for these, PROMIS generically kind of use the 5 T-score movement as a minimally clinically significant difference. The way our graphs work here is the dark green is 1 standard deviation better than the mean. The light green is a half standard deviation better than the mean. The yellow is within a half standard deviation, positive or negative of the mean, and then vice versa, you know, negative. So, you know, this says we're actually doing pretty good treating knee patients within our sports division. We're crossing the MCID, and in some cases, you know, significantly across it. Here, this shows me of those patients that had initial presentations, how did they move? Where did they move from? Were they lower quartile, moved to the upper quartile? So this says, if I sum these two, 42% of the patients moved at least a standard deviation better in physical function, and 23 moved half standard deviation. So roughly 65% of my patients in the knee group moved at least a half standard deviation better. And obviously some move worse, right? We see some patients that are preoperative when we know they're going to decline until, you know, they get scheduled for surgery. But looking at the data this way at an aggregate level, at an administrative level, has never been possible before. So this isn't a randomized control study. This is me using real-time data to evaluate and monitor the program as an executive, as an administrator, as a division chief, so I can see how our team is doing. And again, I can modulate this over time. I can modulate this over different divisions and categories that we look at. But the next layer deeper to get a little more interesting is to say, okay, well, what if we start to go within individual diagnoses? Because now I get more rich, meaningful data that we can actually give feedback to the providers. So within the sports division, within the knee diagnostic category, we start to break out, you know, the top 5, and we can ultimately show all diagnoses treated within this group. And this gives me, obviously, as a clinician, much more meaningful insight and interpretations to see, you know, how we're doing at certain diagnostic categories. But it also helps me to provide feedback to the team and get uniformity amongst the providers in that team on how do we want to code. Right? So if we're not coding accurately, we're not all agreeing that this presentation we should code this way, you know, we get disparity in the data and how people are classified. But essentially we have the same breakdown here. So I can look at by diagnosis now within a division. What was our aggregate delta in PROMIS scores with the MCID, and then, you know, our actual score, and then what percentage of people moved in what category. So then we go a layer further, and a lot of these are really used at our administrative levels, our division chiefs, or like I said, our administrators or chairs. The next part we break it down to is the provider, because ultimately the end unit here is the individual provider. We have a team of 200. The providers need to see their data they need to reflect on their data. They need to see their data benchmarked against their peers so we can move the needle and drive towards improvement across all levels. So that's what we see here. So within my sports division now, within our knee diagnostic category, we have the list of providers that are in that group, their profession, and we give them their baseline starting scores. So a provider can say, you can see an example here, Alexander Carmen, for physical function, this is dark line is the mean of the team, the mean starting presentation of our patients. His patients are starting with, you know, significantly lower physical function. So he's seeing more complex, more severely impaired patients with more physical function impairments. Yet if I go across here, 75% of his patients are going to move at least a half standard deviation better. And he has, you know, 20 patients with full bookend data over the period that we're looking at. So then we quantify, you know, what is the N of the number of patients they have there. So I can start to now dynamically see, you know, whereas this provider here, Gina Brady, her patients actually statistically are significantly less impaired than the mean, right? They're still impaired to the mean US, which would be a 50, but they're less impaired than her peers. So she's seeing less complex patients. Still getting pretty good outcomes, but actually not, if you summed them on an absolute level, not quite as good as Alex Carmen, and he's starting with more severe patients. So the question that I then have is why? Why is that happening? Where is their variation? Is it a variation in their training, in their expertise, in their selection of patients? Why do I have that disparity within the group? So then we ultimately took all this data and said, we need to give this data to our actual front-end providers, because the providers themselves just seeing this data will implicitly have value because they'll be able to interpret it. And behind all this data, the providers can drill down to the exact patient and to the exact encounter that they saw. So as their patient profile builds to hundreds of patients, you know, they can get granular to the actual encounter and look back themselves and see what was done and how the patient interaction went. So the last slide we developed, and we call this the provider transcript. So there's a lot of information here, and the first few slides you saw were all health outcome. What we do in this slide is then we say we take all the health outcomes that we've collected and shown here, and we put all of that over cost to say, as a measure of efficiency or value, how do the outcomes modulate relative to cost? So in this specific example, you'll see here is Tanya Beisberger. She's a member of our sports team. She works in the shoulder diagnostic team. And at a quick high level, she can look at her data and she sees 63% of her patients move significantly better in at least one of the PROMIS domains we assess. And it gives her a benchmark against her peers within these filters. So she's doing 6% better than the mean on her team. And she can go across and look at that. Then she can see her aggregate scores across their shoulder diagnoses. This dark line here is the mean of those of her peers in this group. The dotted line, like we said, was the MCID. So she's a good clinician. She's significantly beating the MCID in aggregate across. And then she can come down here and she can drill down to all of the individual diagnoses and see how she's doing, and identify areas of strength or areas that we may need to look at, or she may want to look at, how do we improve on. We also profile their starting patients' characteristics, right? Because when we started to give this data to the providers, you know, we got the comments of, well, I do see the most severe patients, right? I'm the most highly trained, specialized therapist. I by default, you know, the providers send me the most complex patients. So we give them that breakdown. So this is her initial PROMIS scores. So it gives her distribution of her baseline starting presentation on physical function, pain interference, self-efficacy. So she can say and validate that I do see the most complex patients. We also use some other indicators, because when we looked at our providers and we looked at other studies, well, what other data influences health outcome? Well, we know socioeconomic does, right? So we use this ADI, the Area Deprivation Index, which gives us a measure of socioeconomic stress. So what we present to them is what percentage of their patients are in the lowest quartile of their ADI score. So Tanya's patients, 14.3% of her patients are in the lowest socioeconomic quartile. That's actually 3% below the mean. So her patients are slightly less disadvantaged than the mean, at least from a socioeconomic or ADI score. We give her average patient's age, and it's about equal to the mean. So there's not a big difference there from her peers. And we show her how many unique patients are in her data set. And we call this the provider transcript because if a provider is with us for 10 years, we'll have 10 years of data and we can modulate it over time and we can see, you know, maybe she started to specialize or she became board certified in a certain domain of therapy. Or maybe me as an administrator invest in her, send her to do a fellowship. What is the outcome that I get from that investment or that the provider gets from that investment so we can measure it over time. And then finally, we put the cost data over this. So we give them their total episodes, how many episodes they have in this filter set that have bookend data. What was the mean length of her episode? You know, how long does it take them to treat the providers? If they could be a great clinician, but if they cost 6 times as much, I want to at least understand why. So we put their total cost of the episode and how they compare to their peers. So all this data is transparently given to the provider. And what we're starting to see now as we build these rich data sets and we have this data, what other utilities can we do with this? Well, if you were a patient coming to one of our offices, you'd have over 200 clinicians to pick from. And right now, the way it works is the clinician you get assigned to, there's some generic rules we give to our access center and our scheduling offices. But you would call our access center and you would talk to one of our secretarial staff and they would try to match you up, and most likely it would be based on, you know, first availability within the general domain that you're being referred to. So if it's a knee condition, you're going to see somebody on the knee team, but within our knee group, we may have 30, 40, 50 providers. So what we can start to do now is ask some interesting questions. So if you're a patient, and I use this example with Spondylolisthesis, which is a degenerative condition in your spine. First of all, that probably doesn't mean much to the patient in terms of a diagnosis. What the patient understands is, you know, I can't walk, I can't sleep, I can't manage my pain, and it's a chronic condition. So if you called our office to schedule an appointment, you might get, because of accessibility, scheduled with Nicole Nolan because she's the first available and she's on our spine team. Well, if I look at her outcomes, and if it was a condition of spondylolisthesis and the patient said, look, I know this is a chronic condition. I know I'm going to have to deal with this for the rest of my life. I need to understand how to manage this long-term. Well, then self-efficacy or managing the symptoms would be really important to that patient if we knew that. So maybe Nicole Nolan wouldn't be the best provider for this patient to see if that was their main objective to get out of physical therapy. Conversely, if I knew that, and with the data that we have, we could use some logic to tell our access center who's the best provider for that patient to see by looking at the provider's historical outcomes in whatever domain that patient wants us to help them with. So if that patient said, you know, help me with self-efficacy, I have spondylolisthesis, I've been to rounds of therapy before, I just really need help coping and managing with this. Well, there's a provider named Brian Gusky who's actually significantly beating the MCID, significantly better in this unique domain. So now we can start to get to really customized medicine, where I can ask the patient questions related to PROs and say, tell me what's important to you. I know you have spondylolisthesis, but that's a diagnosis. What function of your life can I help you with? Can I help you with pain? Can I help you with physical function? Can I help you with self-efficacy and managing your condition? And then I can match you like eHarmony does to match a mate with the best provider across the 200 clinicians that we have on who's best to service you based on historical outcomes. So that's one application of this. Obviously, the other application we talked about is getting this to the providers for their own process development and their own kind of provider transcript. We've looked at this for validating a high-performing network. So here at Rochester, we've created an Accountable Health Partners organization, which is essentially a self-insured group that admits providers to be part of their network. Well, right now, a lot of what they're doing in terms of admitting those practices is based on geographic coverage, provide access to patients. The next step you could argue is, if you truly want to be a high-performing member of our network, provide these outcomes and validate it. So that's kind of the project we're working on. There's several use case scenarios here. Another one could potentially be incentive-based compensation. Right now, currently, at least in Rochester, a lot of that is based on RBUs, which is volume and output. You could see a shift if we have a rich data set like this. For certain practices, it doesn't work for all practices. You can start to do measures of value or net outcome change. And those are the type of projects we're working on. So again, my role is really to take the rich data sets we have and find practical operational uses to better the institution and better our patient outcomes and service to our clients and patients. Thank you.
Thank you, Dino. That was really interesting. We are a little bit behind schedule, but I think I'll take time to ask a few questions. The compliance rate for the PROMs, we've been discussing this before. It's not, it's around 25–30%. How do you know that these data are representable and to do these kinds of calculations that you do?
So that's a great point. What we know right now is we do need more data. So this tool was really developed, several months ago, but you can see the power of it once we develop the data set that we need. So we do need a bigger N in this. But the first part of it, like we said, is we need to measure what is our collection rate, because we have a large team, and this gets down to operations. This data allows us to break down which individual practices, which individual offices are doing better than others at collecting it, and find out, who has the best workflows and transfer that knowledge to other groups that maybe don't. So yeah. The key to this is going to be getting the data, right? The data is the asset. Without the data, we can't do anything. So that's an investment that we need to make institutionally. And I know Judy is working at the highest levels within the university to continue to optimize, the workflows that we do to collect this, whether the provider reinforces it, whether it's done automated in the front office, like Judy showed in that video example. That's an ongoing piece that we need to deal with in terms of increasing the collection rate. But the point is, we're committed to this, and we know we need to get the data. So one way or another, we'll innovate and figure out a way to collect the data more efficiently and build on this as we go.
We also, sorry, I wanted to say, we know that the data has limitations at this point, but we also see starting to expose this tool as a way to drive better collections. We can show providers their individual data and what could come of it if they get their patients to fill out the assessments all the time. So we see it sort of working on both sides.
There's a few questions coming in, and one of them are related. These are for physiotherapists. Have you, considered broadening this to include physicians? And again, how is it to discuss these data with underperforming therapists? And can you discuss that part a little bit?
So we started with this with therapists because obviously, when Kathleen and I started the project, based on my role, it was easiest to implement that with therapists. And the reality is it's just a lower profile group and less sensitivities than starting this off with physicians. So intentionally, we're trying to work out the logistics and look at the adoption rates of this with our clinicians. And I think genuinely, the point of this is to enhance all of our providers. So the intent of this is to identify weaknesses, and then I would look at myself as the administrator, or if you're the chair or the chief of the division, what investments do we need to make into our providers to move the mean? I don't have any doubt that we have great clinicians, but they themselves have never looked at data like this in an aggregated form. So once you present the data, inevitably the mean moves up. And it's my job as an administrator to invest in those clinicians. If you use this tool as a stick, obviously that'll affect your adoption rates potentially with your providers. And maybe that's a strategy that you would want to do. At the university, we're using this as a carrot. And for me to decide, I have limited resources on what we invest in. Where can I identify those areas that we need help in and invest in those providers or those practices or get them the resources they need to improve the needle. But the point is, I can now measure the value of that. And when we make investments, we can look towards key data metrics for the clinicians to strive for, or key data metrics to justify the use of those resources.
Hey, Krista, I just want to tell you that the next, the group that raised their hand to be the next guys on this platform are the neurosurgeons.
Yes.
They are in. It's, you know, and it was volunteer. It's not stuffing it down anyone's throats. It's people interested in looking at their data so that they can measure it and manage it.
I think culturally, you know, my team, because of my background and other projects I've done kind of on these data analysis and providing data to them, culturally, we measured a lot of this stuff. It was really putting it together, giving it to them in a dynamic fashion. So I think the reality is the trend is going to be to move towards this, not away from this. So either we adopt it and learn what our weaknesses are and fix them, or we let somebody else do it and, you know, put the data out there.
Yeah. We've
Thank
also,
you very much.
you know, worked.
Yeah.
Sorry.
I think we have
just wanted to add, you know.
Yeah. Please. Okay.
No, go ahead.
No.
I was just going to say, you know, we've tried, I think, from the get-go to really get buy-in from clinicians on this, and to be very transparent about the data and to take it seriously when they say to us, you know, my patients are affected by, you know, the no-show rate or by their socioeconomic status. You know, we're not coming into it kind of with the approach that we know everything about the data and we're putting it on the clinicians and they just have to come along with the program. You know, it is a partnership, and I think that's a really important piece of making this functional.
Okay, we are a little bit behind schedule, but this was so interesting, and I didn't want to interrupt you. I think we'll just go straight on to the New England Baptist Hospital and Dr. Scott Tromenhauser. I mentioned that people pointed me towards Rochester when I was there at Harvard, when I came to Harvard first, but they also brought up Dr. Tromenhauser, which has been working to implement PROMs and especially predictive modeling into clinical care. It's a really innovative solution. We're trying to put Dr. Len Dovolio, which is head of SHIFT and has been helping Scott with this solution. There he is. And so Scott, please.
Thanks, Krister. Hey, these last two presentations are great. I love the way people are using the data in such an innovative way. It's nice to have the investment to produce that kind of platform. I wish I had those resources, but we're doing the best we can, and I'll go through what we are doing. I hope the quality of my sound is good enough.
Yeah, I hear you good.
Okay. And my slides are coming through, hopefully. Okay. So I'm going to do, we're going to take a walk back in history a little bit, and I'm going to put this into perspective and be a little philosophical about what we're talking about. And we've entitled this Closure for Codman, and I'm going to tell you who Ernest Codman was in a minute. And a lot of the work that I've done has been augmented considerably by Leonard Dovolio, who was placed on this panel, I guess, as well. And he may be able to comment, although he's texted me that he's having some internet access issues. In any case, Ernest Codman, this is his gravestone in Mount Auburn Cemetery. If anyone knows Boston, you know it is one of the most beautiful cemeteries probably in the world. It's about a mile or two from my house. And at the bottom of this plaque, it says that he's the father of outcomes assessment and quality measurement in healthcare. And a quote from him says, "It may take 100 years for my ideas to be accepted." He said that about 1925. So I think he was just about right, and we still have a long way to go. This is who he is. He graduated from Harvard Medical School and joined the staff in 1895. He's an interesting character because he wrote the first English language textbook on X-ray techniques. He instituted the first morbidity and mortality conference at MGH. He started the first tumor registry in the country. And he developed what he called the end result system in 1910, which we would call outcomes assessment. Unfortunately, because he suggested that surgeon competence be evaluated through the system, he was basically booted off the staff at man's greatest hospital. Ultimately let back in, but he was quite a character, and I think the reason he was booted off more because he was a bit brusque, impolitic, not particularly diplomatic, and he just rubbed a lot of people the wrong way. In any case, he did some amazing things. He went on to be one of the founders of what became the Joint Commission and the American College of Surgeons. He died in 1940. He's now getting recognition because they have a Codman Center for Outcomes Research at Mass General now. So he is a kind of our inspiration. Len and I both have walked through Mount Auburn Cemetery to find his grave. And this is a quote from him: "Every hospital should follow every patient it treats long enough to determine whether or not the treatment's been successful. And if they've not been successful, why not?" And we heard that, I think, from Dino, exactly that, that sentiment. And no talk like this would be complete without some mention of value. And everybody knows the value equation. If you're in Boston and you're at all involved with Harvard Business School, Mike Porter, as Krister and I both are, you can't get away from this. And so we have to throw it in every single talk we give, even if it's about you know, the cost of cheese in Switzerland. In any case, what it is not is cheap, skimping, stinting, or cutting corners. It's based on outcomes that, it is not based on outcomes that matter to payers, providers, or government. It's really about patients, and that's been stated in the previous talk. I want to make the distinction in people's minds about what outcomes are, and very often outcomes are defined as quality indicators, which indeed are outcomes, but they're really measures of harm, things such as surgical site infections and falls and CAUTI and CLABSI and HAPI and things of that nature. I like to focus more on patient-reported outcomes, which are measures of benefit, at least you hope. I have a whole quality team at my hospital that worries about the harm, and that's great, but I really want to focus on whether or not we're actually helping people. You know, I'm in a very competitive medical environment where everyone claims to be the best hospital in the world, and yet no proof has been given for that claim. When I took on the position several years ago of managing this project and became the chief medical officer, I said to my administration, we have to stop saying we're great, and we have to prove we're great. And let's find a way to do that. So I think we're on a path towards that end. And so I like to think about ways to use patient-reported outcomes. Some of that's been illustrated today. Some of this is obvious. I hope I'm preaching to the choir, but you can track individual patient outcomes from treatment, which we've seen. You can track population outcomes, such as all patients with knee arthritis. You can compare outcomes between treatments. How does non-operative treatment for a back problem compare to operative treatments, provided you have the outcomes? You can do compare outcomes for individual providers, like Dino showed us with his physical therapist, and you're on the right track, certainly getting the surgeons involved. And you can track outcomes over time for providers. And that's an interesting point we haven't heard, because if you see a deterioration in outcomes with a particular provider, you'd want to ask why that is. And you can certainly use PROs to predict outcomes, which I'm going to talk more about in a bit. So we came upon this notion about the outcomes from total knee replacement when one of my top total knee replacement surgeons said that the results of total knee replacement aren't as good as we wish they were. And in fact, some of you may remember 3 or 4 years ago, I think it was, there was an article in the New York Times, that great medical journal, outlining this problem about the failure of total knee replacement in many patients. And so if you look at the literature, 10 to 30% of patients don't achieve minimal clinically important difference in their patient-reported outcome scores. So we took a look at our scores at the Baptist, and indeed, 22% of our patients did not achieve MCID. And this is just looking at the visual analog scale. We collect that as well as Hoos and Coos Jr., the knee osteoarthritis outcome score. We also collect PROMIS, physical function, CAT scores on all of our arthroplasty and spine patients. And I should mention that we are an orthopedic specialty hospital. That's all we do. We do about 7,000 or 8,000 total joint replacements a year. My busiest surgeon does over 800 cases a year. So we have a rich data set to dip into, and we've been trying to collect outcome scores now for 3 or 4 years. Talk a bit more about that. We've set up a registry probably around 2008. And as software within the hospital has improved and electronic medical record was developed, we started to expand the capability of that registry. Now we have about 265 patient elements, not counting the patient-reported outcomes in our registry. The patient-reported outcomes are also put into the registry. We use REDCap right now to store this data, and we are now moving to a different platform for the main reason being that we were only able to collect about 45% of long-term follow-up scores from patients, which is generally considered pretty good, but we'd like to be up more around 75%, because we don't want to hear the criticism that's already been raised here that, gee, it's only X percentage of the patients who have responded. We really want to get up closer to that 75–80% mark. We're moving to a platform, no interest in the company, but Patient IQ. We had looked at a number of companies a few years ago. None of them could do what we needed to do. This is a newer company, and they really haven't figured out. So we're excited about that possibility. In any case, when I looked at individual surgeon scores, this is what I saw. And what I saw, I didn't really like, because I saw the variation, and everyone should know that variation is the enemy of quality. And so we had to ask, well, why are we seeing such a difference in what was being achieved by these particular surgeons? So these are my 9 busiest arthroplasty surgeons. They count for about 90% of what we do. And you see this variation in each of the scores, the PROMIS, the CUS, and the VAS. And we also saw a difference in the median pre-VAS score between the providers, which is an interesting point I think we'll come back to. The number of procedures are not the number of procedures they did, it was the number of patients who actually responded. And this altogether was about 750 procedures represented here. We had done a run through on this with about half that data. The results were essentially the same, and we're getting together another tranche of data, which will probably be considerably more than that, to run the model again. But you can see just by looking down a column the variation for each particular surgeon. And we're trying to get our heads around why we see such variation. And so we started to say why, and thought about all the potential issues. You know, was it technical? Did we have one surgeon who was better than another surgeon? Did one surgeon have more complications than another surgeon? Well, it turns out in my institution, our infection rates exceptionally low, probably one of the lowest in the country, as well as DVT and all the other measures of quality that you see. We're doing particularly well, and in many are rated #1 in the state by CMS, the Centers for Medicare and Medicaid Services, often best in country. And these guys are very well trained. So it's not really a technical issue. We're not seeing intraoperative complications. So we discounted the technical issues and said there must be something to do with patient selection. Either they're operating too early or too late, or they're not setting expectations for results from the surgery. And so what we did is we wanted to see if we could predict the outcomes of total knee replacement before surgery. So Len DeVolio and his company SIFT took the data and applied a machine learning model, a random forest model. If you know anything about it, I'd encourage you to look it up just to understand it better. And we found that there were some factors for our particular population that were predictive, if you will, that mattered when you do the analysis. And here they are. Some of them are individual questions from the surveys. Some are family history and patient history items. And if you do this analysis on your patients, that may be a slightly different list, perhaps. And we decided that there was perhaps a way to set expectations better for the patient. And we recruited Dr. Glenn Elwyn, who's one of the fathers of shared decision-making thinking. He's at the Dartmouth Institute for Health Policy and Clinical Practice at Dartmouth College. He's a great guy, and he came down and gave grand rounds at my hospital, and this is what he said. And shared decision-making is an approach where clinicians and patients share the best available evidence and try to make decisions together. And it's not the same as informed consent. Many providers are very confused about what this is. Most will say, oh, I do shared decision-making, when in fact, that's not at all what they're doing. And if you think back on some of the previous presentations, there's always a wide range of reported outcomes on these surveys and the results of the surgery itself. So very often someone will say, oh, 85, 90% of patients do great with this procedure. That's true, but that may not apply to that particular patient, which is why we wanted to try to develop a way to predict what the outcome might be for that particular patient, and then share that prediction with the patient in a shared decision-making process. And I want to run this short video. It's 2 minutes, and it really kind of goes through exactly what we did with SIFT, and then I'll expand on it afterwards. So let's hope this pops up. There we go.
I'm sorry, Scott, but I don't see any video. I think it's not working.
You're not seeing it?
No.
Oh, that's too bad. Hold on 1 second. Can you see that, Krister?
Unfortunately, not. No.
No. Interesting. Maybe if I get rid of my slide deck. How about now?
No.
Huh.
That's not working. So I suggest if you just
Yep,
walk us through, and
yep,
maybe even Len can.
Yep. All right. So this is a tool that we developed that looks very similar to one we saw earlier. The patient answers a series of questions when they come into the office on an iPad that has to do with those predictive factors you saw before. And for that particular patient, the prediction is made about their chances of seeing improvement on the left, staying about the same, or worse after surgery. So if you share this with a patient, rather than telling them that 80% or so of patients do great with this surgery, they may make a very different decision about moving forward with surgery than they would if they saw this. So they may see this and still decide to move ahead with surgery, but at least they're better informed. You know, if this said they have a 5% chance of improvement, you might strongly suggest they don't consider doing the surgery. So I think this is where shared decision-making comes into play, and you can, and having this personalized prediction for the outcome for the patient, I think is really useful. So that's what we've worked on. Our next project will be around spine surgery for simple procedures that we can get our heads around, such as the most common thing we see these days, spinal stenosis with spondylolisthesis, which is the treatment of which is somewhat controversial. We actually looked at how it performed. So this is what was predicted against what was the actual outcome. And if you look on the left, 50% patients who improved, it was predicted that they were about 50%. So the model did quite well. As with all predictive models, the more data you have, the better, which is why we're going to run it again. Hopefully we'll see even more predictive accuracy, but in any case, it's a good place to start. So what we're now doing with this is having several surgeons use it in their office. Once we've sort of been interrupted by COVID, but once everyone's comfortable using it and they put it in their workflow, we'll start collecting outcomes on the particular patients who've seen the model to see if there's been any improvement, whether we've quote unquote talked people out of surgery, just overall see what the outcome of using the instrument actually is. So, you know, the argument for something like this is that there are about 700,000 knee replacements done a year in the US. It's the #1 expenditure for the federal government in healthcare. And if you have 22% poor outcomes, and it costs about $25,000 for a knee, that's where the $4 billion a year gets wasted. In the coming years, the number of total knee replacements are expected to increase significantly, and by 2060, 2.6 million a year. That would have come up with $14 billion in waste if we don't do something differently. So our approach is we need to do something differently than what we're doing right now, so I'll also point out that some of the problems that the other folks have mentioned about getting provider buy-in, the hospital itself has decided that this is a strategic imperative for them to track outcomes. So this is actually done through the hospital, doesn't involve the providers except using the tool, but the collection of patient-reported outcomes is done by the hospital. 98 or 9% of our patients come into our pre-screening unit before surgery. That's where they do their preoperative PRO input into an iPad, and then we send out reminder emails to get the follow-up. The new vendor that will be using Patient IQ really are experts at this. They're going to probably use text as well as email and telephone calls if that's even feasible with the number of patients we have. In any case, the surgeons don't have to be involved. We found in the past that was the weak link when we first started doing this. We had only a few surgeons who were willing to put the work into this and plug it into their workflow in the office. So that we saw as a real barrier. Now with the hospital managing it, where we think we can get much better data. So something you should always think about with efforts like this is, you know, what are we doing in terms of our treatment? Is it working? And what should we be doing if it isn't? So this is what Len DeVolio loves to talk about. I would encourage you to look him up on YouTube. He's done some fantastic talks about the use of data, predictive analytics, how to think about this in our environment. And I don't know if he's able to jump in at all here, but I find his thinking is really critical and insightful. So I'd encourage you. SIFT itself doesn't typically do projects like mine, but Len altruistically has agreed to help us with our project. And we would love to see collaboration between institutions. We're certainly open to that. It's a way to get bigger data sets, and the bigger the data set, the more accurate sometimes the predictions can be, and we can share lessons learned and advocate for higher quality outcomes. So something to think about. I'm always willing to talk. There's my email address, and easy to engage by that method. So thank you, and happy to answer questions.
Thank you, Scott. That's really interesting. Len, could you unmute and maybe put on your camera? I see that you've been brought in on the panel.
Yeah, can you hear me all right?
Yeah. Welcome to the panel.
Yeah, no, it's my pleasure. I don't see a button to share video. The only button available to me was to share audio. but I don't think you're missing much with that, and I'm happy to answer any questions folks have. One thing I'll mention, that last slide that Scott just put up, which showed basically other institutions being able to access what we did. I think when Scott and I agreed to work on this project together, we had said, well, it would be wonderful to be able to help the thousands of patients that move through his institution. But as everyone on this call knows, you get real value from data when you start to use it to learn, not just at one place, but beyond. And I think our ambition from the start was to invest in basically subsidizing the development of this so that we could invite others to use it at much lower cost. We wanted to figure out if this works at all. And then we wanted to give it to as many institutions as possible with the hopes that we might be able to make Codman's vision a reality. This idea that every institution could measure what are we doing and is it working and what should we be doing was really the inspiration, and that inspiration sort of dies as an idea if it's just a thing done in one place. So I think both of us are agnostic as to how to make it work, but both of us are ambitious that what we have done here may become more the norm in other places, and are willing to be creative as to how to make that possible. But I know I preach to the choir in saying that, that this is incredibly powerful, but limited if it remains, all of our efforts are powerful, but limited if they remain locked in one institution as opposed to put out into the world.
Yes, and very interesting. And can I ask you, Len, a few questions related to machine learning? We're not as trained as you are in that topic. A few questions, like one, like when do you know that this algorithm know enough? Like how much data does it really need to be perfect or almost perfect? And yeah, you can start with that.
So I think of it exactly the same as you would any statistical analysis. It's not a black box. You feed in data that you hope is predictive, and then you measure how predictive it is against a control group. In this case, very much like statistics, you set aside a certain amount of data to train the algorithm, and then you set aside a certain amount of data to test whether or not it actually worked. Here, what you've seen is, and then, by the way, how good is good enough is dependent on the problem you're trying to solve. We had, as Scott mentioned, 757 cases here to both learn and evaluate against. And what we decided as a combined team was, good enough was, if it's mostly right in predicting which patients will do better, the same, or worse. And I can't remember the exact statistic that we settled on or how close we got to it, but we did share with the clinical team, all of the surgeons participating, how we had performed. And I think because of the limited sample size here, we also had to combine stay the same with getting worse in order to conduct the analysis, because we only had 757. So, I mean, again, as in any statistical analysis, you have to decide, how will this be used and are we willing to put it into production? And here, I think we did a root mean squared error where if we predicted the likelihood of improvement, could we be, plus or minus 10 points of that likelihood? And because it was designed to promote a conversation, we were okay with getting that close.
And to really know that this works, that this actually saves the $14 billion that Scott mentioned, you really need to do a randomized control trial, don't you? Or control it against the historical data set. Am I correct?
Well, so that's a bit loaded. No, I don't think you need to do an RCT to figure out if something saves money. I do think you need to do an RCT to truly know whether or not the introduction of this intervention led to more appropriate surgeries being conducted or fewer inappropriate surgeries. That I would agree with, although I'd still feel pretty comfortable in doing a proper case control. The bigger issue is the incentive, right? And I say that because you say to know whether or not it saved $14 billion. right now the top priority of surgical institutions in the US is to finally get back to conducting more surgeries. And this intervention is designed to reduce the number of inappropriate surgeries. So yeah, I mean, the greater challenge, the reason why I refer to this as a project and not a product, and the reason Scott and I agreed to do it because we were both intrigued and thought it was the right thing to do, as opposed to a financial venture, is because unfortunately in this country, it's hard to get most surgical institutions that operate in a fee-for-service model to invest in technology that would lead to potentially fewer surgeries. This is why Codman was fired, right? I mean, this is why surgery today, it's not commonplace to do what Rochester and SIFT and NEBH are doing, because to spend money to reduce output gets people fired.
We are moving into the sort of the last part of this webinar. So if all the panelists could put on their cameras so we can all see you. And I'll throw the ball to Dr. Lars Vosley in Oslo. You've heard now institutions from experiences from institutions in the US about both how to match the patients with the right provider and also now machine learning model. Do you think there are any of these solutions that could work in Norway, in a Norwegian setting? You have to unmute. Now you're on.
I think we should love to have a machine there that could help us deciding which patients we should operate on. But we really haven't found that yet. So if you have found something there, that would be interesting. I think we have the same, very similar data as you have in the US, that about 20% of the knee arthroplasties is not successfully. We have tried and we have worked for that for very many years now to try to find out if there is any parameters that we could, or things that we could use to find out which are these 20% patients, and we have some studies going on that, but we have not really found it. So I think perhaps one of the advantages in Norway compared with what you say is that we don't have the same economic incentives for our health system. I don't think you would be fired if you found out that you should not operate on some patients. The Codman's idea that we should ask what happened with your operation and was it successful? It's very much easier to follow that here. We have had a study here with a shame operation that showed that perhaps the operation didn't work at all. And I think our health system is more open to really try to find the correct operation. Whether it's give any income or not is not that important in our system. So that's perhaps one of the big differences between our two systems.
Yeah, can I comment on that? So I'm fortunate because we have so many providers who do such high volume. They have wait lists to get in the office, wait lists to get in the operating room. They're not concerned about doing a few less, they wouldn't do less surgery. They would actually wind up booking less surgery, but that would just shorten the wait time. There are places where I'm sure somebody's doing 100 or 150 joint replacements a year, and if you reduce that by 20%, they might actually feel that. So that's a concern, but not at my institution. But in any case, it's still the right thing to do to avoid operating on people who won't benefit from the surgery. So that's the message that you always have to remind the surgeons that, listen, yeah, okay, your volume may drop, but it's the right thing to do. And that's what motivates us.
There's a question commenting regarding the New England Baptist solution and SIFT. Is the data integrated with the electronic medical record? And where are the PROM scores stored?
So I'll answer that, Len. So it is not, because we have our electronic medical record is Cerner Sorian, which is not great, and now becoming fairly dated. We're on a path to use Epic. We're part of a 13 hospital system that's newly formed just over a year ago. Some of the hospitals are Epic, some are not. We're all trying to get to the same platform. I know there's probably some people on this call that think that's just where the hell have we been? But in any case, eventually, I think if we can get an Epic, we can certainly put all this together in one place.
Just one more note to that. I think there's a real distinct advantage to not having to live inside of a specific EMR. So that was by design. We wanted to have the 90 seconds worth of preoperative questions live on an iPad, and the PROMs data has always lived in a third-party system. I do think it would be helpful to reintegrate at some point, but in designing information systems, at least in the US, dependence on the EMR can be the death of an idea pretty fast.
Could I ask Rochester to comment on that? What are your experiences with that, with integration with EMR and electronic medical records, for those who don't know what that is, and then the solutions that you're presenting? Kathleen, maybe?
Yeah.
So our setup right now is actually fairly similar to what it sounds like you have at New England Baptist. We developed the UR Voice platform separate from Epic, our EMR, because at the time that we started implementing Promise, Epic couldn't deploy computer adaptive questions. So we have, a separate system for collecting data. The data goes into a warehouse managed by the health lab, my group. And we have some integration with Epic. So the scores, the end scores and the visualizations that Judy showed do show up in the medical record, but all the data is not there, if that makes sense. We are on a path to switching over to all of Epic's native tools because now they can support doing patient-reported outcomes on iPads. And we're very much in the process of scoping out exactly how that's going to work and what the trade-offs are going to be for us switching from our own homegrown system.
Judy, can I ask you about how is Rochester working with the similar models, like the predictive model that New England Baptist is working, or do you see, it seems like you are moving a little bit in a different direction when it comes to handling PROMs in the institution?
Yeah, well, I think we do it at site of service. Sure, we look at aggregate data, but we're trying to encourage, as Dino tried to, I think, highlight that, I don't know if you appreciated that his platform that he was showing you, or his program, was actually being updated live. You saw the little thing going, and the data was coming in right at that point in time. I think at the time at the site of service is really important for us to highlight for our providers, so that they could get a feel for the data as it's being collected and as they go patient to patient. And then you use the aggregate data to give you some power around the numbers. So, I think we're doing a lot of the same things. We might look at things a little tiny bit differently, but actually that's the joy. That's the part of it that makes it so exciting, is that all of a sudden you have an aha moment because you heard Scott say something that was amazing, or Dr. Holman, and all of a sudden you can sort of start to look at things a little tiny bit differently. But I think having different ideas and different groups think about things differently will provide us even more insight. Hope that answers it.
It seems that all systems, though, in Oslo and Boston and Rochester, are struggling with respondent rate for follow-up PROMs. Can I challenge anyone to say, how we should, how can we overcome that and get respondent rates that are close to 70–80%?
I'll make a quick comment. I think that somebody said it, that you have to make this data helpful to the provider, so that if the provider sees it and realizes it's actually going to add to their visit with the patient, then it's going to be helpful. And that's some of the things that a lot of the groups have been doing, and we've been doing, trying to highlight why it would be important to gather this data. Because as was said, a lot of times the old school is, I already knew that. I already knew that. But I can tell you, I go into a clinic room and I say to the patient, hey, how you doing today? And they say, I'm doing great. I go, oh, great. Are you back to work? No, I'm not back to work. So all of a sudden I have this dance of information until I get to where I need to be. And I think that that's what, for us, patient-reported outcomes have done best, is when you ask some information, it gives you a validated history. And then you can use that information to jump forward in your visit to accentuate other treatment options. And lastly, I'll say that if you actually took, and I think Scott said this, there's many, many different outcomes measures that are out there that are not patient-reported outcomes measures. And yet somehow we're challenged with having to check boxes saying that we've performed these for quality measures when they're not even quality and they're not helpful. So, you know, my constant mantra is get them off the table and add something in that is going to be helpful. And I think that if we get the eye of, you know, the government and insurers around some of this, that would be powerful.
You're muted. You're muted, Krista.
Thank you. So yes, Scott, how do we get the attention from the government and the payers?
Well, it's already started. So I've had discussion with a couple of startups who are on a path to help payers direct patients to providers who are able to provide the kind of data that all of us are talking about. And I think that's going to be very successful for them, because the providers have no way other than looking at the claims and the costs to understand whether someone is doing a good job or not doing a good job. You may be able to provide a great outcome at a high cost, and they'll just overlook you completely. What you want to do is provide a great outcome at a low cost, but they don't have the outcomes. So these intermediaries will come to you and say, give us the outcomes. We'll connect you to a payer to direct more patients to you if you have better outcomes. So I think that's definitely coming. No way around it. In fact, some of my providers say, stop doing this work, because if you do this work, then this information will be out there for payers. I'm like, well, that's the idea. I think we're going to see more of that in the next year or two, for sure.
Can I throw the ball to Dr. Lars Bastley regarding that? You've been working actually in Boston, and you've been to the New England Baptist Hospital. You know the difference between the Norwegian health services and the US health services. You see any difference in incentives and how to engage the government with the payers to focus more on patient-reported outcomes?
Well, I think the government also will try to stimulate more focus on patient outcome, but I think they will use other incentives than direct payment. I think they will try to improve the results by giving some measurements on quality. These quality measurements will come into what we are going to report to the government, and then you have to have those answers right. I think it will come, but it will be quite different, I think, in the US and here.
Because as I understand it now, there are some payers that are mandating collection of patient-reported outcomes, but there's no benchmarks existing anywhere, are there? Anyone want to comment on that?
At the moment.
Not even in the Norwegian sector, right?
No, not much.
But
what about in the US?
Not that I know of.
Okay.
You know, you might want to ask Dino, you know, so PT is a little tiny bit different in that they actually are required to provide outcomes in order to get paid. And that was one of the many reasons that Dino moved ahead with this program with Kathleen and the health lab. Dino, do you want to comment on that? You're on mute or something.
I would say payers are asking for it and they want it reported, but there is not a good baseline metric to understand. Even our own practice here, you know, I can show you slides of conditions that we're we're not showing positive outcomes, but we need more data to understand why. Was it the selection? Was it they not matched the right provider? So the key is obviously more data. Data is the asset, and I don't think anybody has a good benchmark on what we would expect, at least to make those kind of hard payment decisions right now. But we'll get there as we get more data and we learn more from it.
And actually, if I could jump in, Blue Cross Blue Shield of Massachusetts has asked for outcomes data, but you're right. You know, they just asked for the data. We don't know what they're doing with it. I don't know how they're using it internally, and it's not affecting whether we get paid or not. Only that we must give it to them, and it's only for some products, not all products. So you could tell we're headed in that direction, and probably a year or two away once they figure out what they're going to do with that data. So,
you know, a group that I find interesting for this kind of stuff is you look at what is a true value-based care model currently, and you look at a lot of self-insured employers. And actually, a lot of the work that I started to do was around workman's comp here at the university, which is self-insured. And we spend about $14 million a year on workman's comp claims. 90% of those are musculoskeletal. So my first project that we did framed around this was looking to see, can we predict and identify individuals that were at high risk for workman's compensation claim based on PROs and some other factors, and then provide intervention to reduce that risk, and we did. So, you know, it's all about the incentives. If the incentives aren't aligned and we're not using these to drive incentives, then none of this will matter, because it just doesn't, at least in the US, you know, change behavior. So the point though is, as we build this, if you look at high performing value-based networks, if you look at true value-based, you know, self-insured groups, those are high areas that I would target now to start to show this and say, because as an employer, they have a discrete identified population, they have a captive audience that you can access, they can enforce compliance with collection. Those would be the high profile groups that I would see as early adopters of this type of use versus, you know, Medicare or the government payers or even some of the private payers.
So time flies and we're actually moving to the end of this webinar. I just want to ask one last question before Per-Arne Holman makes the closing remarks. It's been suggested here ways to collaborate. Len talked about sharing data or training algorithm. How can we together drive this forward as providers on each side of the Atlantic? And do you see any potential for collaboration? Anyone?
yes.
Scott, please.
So as I said, I put my email up there, and I'm always willing to consider that sort of thing. Len can help us with to some extent, I imagine, and Rochester certainly has sophisticated data management capability. I don't see why this couldn't work, because we probably have a ton of data between all of us.
Judy, please.
You know, we have collaborated with others that are collecting similar patient-reported outcomes just to validate our data. I showed the knee replacement probabilities, but we actually went over to Utah and ran the data for foot and ankle that we did here at the University of Rochester, because people said, oh, that's at U of R, you know, it's not going to work around the world or whatever. And so we went over to Utah, grabbed their data, and they had exactly the same threshold values. So I would tell you that working together, we will do great things.
All right. Thank you. Per-Arne?
Yes.
Thanks to you, this all was arranged. So I'll leave you with the closing remarks.
Thank you, Christer. I'm sorry if it's been confusing that different faces are behind the same name during this webinar, but we are sitting in the same room. My previous research has been on the referral process, waiting time, and readmissions, mostly on administrative data. Since 2012, for the first time, I met a vendor of PROMs, the Norwegian company Checkware. We have been working together since to build a solution for scaling up routine collection of PROM in mental health care and lately also somatic care. So that's a parallel system, and we sort of stand on the shoulder to Einar and his solutions. We combine PROMs with administrative data and cost. The model is called LovePROM, Lovisenberg Electronic PROM. Isn't it nice? I have a seat in the advisory board for 2 national quality registers for mental health care in Norway, working on including PROMs in these protocols. On a national level, we struggle to integrate data sources and technologies. So what we have heard here today, nurture a hope. It's a common struggle, but I think there are opportunities here. We have reached the end of today's webinar. But first I want to thank Judy, Dino and Kathleen from Rochester, Scott and Dan from New England Baptist and SIFT, Einar and Lars from Lovisenberg. You have all shared your expertise and experiences with the use of PROM in orthopedic practice. It was generous, full of insight and very inspiring. On the organizational and technological level, Norway have much to learn from hospitals in the US, but we would also look for an opportunity to benchmark on outcomes. Giving patients a voice in a clinical setting have the potential to improve doctor-patient relationship. It empowers patients to take informed, shared, and probably better decisions together with their provider. Results matters most to patients, but also the way services are delivered. I believe including meaningful outcome in planning, delivery, and follow-up on health services is in the core of quality improvement. Clinical relevant PROM will engage patients and clinicians. PROM can create value for patients, providers, insurance companies, and society, but only if provider uses them to improve. With the support of managers, clinical champions, vendors of technology, it is possible to grow a culture where patient voice reach longer and create more values. In fact, my mother-in-law was a surgical patient here at Lovisenberg. Her reports on pain and functioning left the consultation room. Her voice was amplified and broadcast by Einar so that Lars could hear it. And later, it reached out to scientific papers. It changed surgical practice in Norway and has improved health outcomes for thousands of patients. PROM is indeed a power. Whether you work with patients, back office managing hospitals, with commissioners or providers, governmental bodies or private vendors of technology, I hope you were inspired too today, and that you will work together with us, giving more patients a voice. I close this webinar with an invitation to meet again and to work together from Norway, US, or virtually on the web. And finally, thanks a lot, Chris, for the efforts you made to set up this meeting with good help from Anja, Tyler, and others. We are really looking forward to seeing you back in Oslo soon, hoping you will find opportunities to serve in the diplomatic PROM Corps in Oslo. Goodbye from Oslo.
Thank you, Oslo, and thank you to everyone on the panel and for outstanding presentations. This webinar has been recorded. We will put it out and we will notify everyone on that has registered for it. And with that, thank you again and have a good day.